webinars. Today we have the pleasure and the honor to introduce Dr. Claude Steriade. She's an assistant professor of neurology at the NYU Comprehensive Epilepsy Center. She completed medical school at McGill University in Montreal, Canada, and then an adult neurology residency at the University of Toronto in Canada. She then moved to the US to pursue an epilepsy fellowship at the Cleveland Clinic, where she married her interest in epilepsy and clinical neurophysiology with neuroimmunology by investigating electroclinical phenotypic signatures of autoimmune encephalitis. Since joining the NYU Epilepsy Center in 2018, she has expanded her research interest to identifying patients with focal epilepsy related to autoimmunity and biomarkers of autoimmune-associated epilepsies to novel imaging tools. Welcome, Dr. Steriade.
Thank you for having me. Thank you for the invitation. I'm going to share my screen. I'm going to talk to you today about seizures associated with autoimmune encephalitis and also chronic epilepsy that has an autoimmune cause. These are my disclosures. And what I'm going to focus on today is what the general phenotypic features are of autoimmune encephalitis, and I'm really going to focus on the electroclinical features that are of most interest to us epileptologists. I'm going to talk about the recent International League Against Epilepsy conceptual definitions of seizures and epilepsies in the context of autoimmunity and what it means practically in terms of our clinical practice. And then I'm going to talk about some scoring tools that are available to help us identify these patients and diagnose them. And then finally, I'm going to wrap up with some diagnostic principles. Because of time, I'm not going to get to the treatment piece in this talk because that's a whole other discussion. So autoimmune encephalitis has become increasingly recognized as a treatable cause of encephalopathy. And in fact, recently there was an epidemiological study that looked at the incidence of autoimmune encephalitis compared to infectious encephalitis, including, viral encephalitides, other infectious causes that are proven. And it was demonstrated that in the last 10 years, and when I say last 10 years, I mean between 2006 and 2015, when you compare to the prior 10 years, 1995 to 2005, autoimmune encephalitis became a much more common cause of encephalitis compared to infectious causes. And this may be due to our increased ability to diagnose these patients who may have previously been mislabeled of having a viral encephalitis. So the other possibility is that there's a true rise in incidence of this disease. And when you look at how you diagnose these patients, there are a few key characteristics that come up. There are available diagnostic criteria that were developed by a panel of international experts, primarily neuroimmunologists. And really, when you read these diagnostic criteria, which importantly don't really include neural autoantibody testing because they acknowledge that there are places in the world that may not have access or easy access to quick turnaround neural autoantibody testing, the few key clinical characteristics that are listed essentially include subacute onset of neurologic dysfunction, encephalopathy being a core feature with or without other neurologic features of which seizures are often present, and some ancillary testing to support the diagnosis, which can include imaging, CSF abnormalities supporting inflammation like phagocytosis, and merely histopathology. And lastly, the exclusion of other causes, including infectious causes, vascular causes, and malignancy. There's an echo when I'm talking. I can hear myself. I don't know if everybody in the audience can hear me okay, but I can hear a lot of echo right now. So I don't know if there's a possibility of maybe somebody else muting themselves. In any case, I'll continue, although it's a little bit distracting for me. That's still hearing echo. In any case, these are the diagnostic criteria for possible autoimmune encephalitis, which I've listed here, which include a constellation of the features that I just listed. So I'm going to start with a typical case, which many of you will right away be able to diagnose. This is a 25-year-old woman who was previously well, presented to an outside emergency department with new onset psychosis. She was treated with antipsychotics and rapidly worsened, developed catatonia, extrapyramidal syndrome, and was transferred to our hospital, was found to have dysautonomia. She had labile blood pressure and increased heart rate, and ended up being intubated for decreased respiratory drive. What I didn't mention here is that she did have 2 tonic-clonic seizures early in her course. Very distinctive phenotype, which includes usually a prodrome of psychiatric manifestations, which are typically followed by neurologic dysfunction with speech abnormalities, seizures, and then patients often evolve to movement disorders or facial dyskinesias, encephalopathy, dysautonomias, a common manifestation, and so is central hypoventilation. And these patients very often have abnormal EEGs. Generalized rhythmic delta that's quite pervasive is actually the most common EEG finding you'll see in these patients when they're critically ill, but also there's been the finding of extreme delta brush that's been described and is less common, and when it's there, it tends to not be there very often. So if you're not able to perform continuous EEG on these patients and you're obtaining serial routine EEGs, you can't necessarily count on seeing this finding. The important thing here is that these patients are critically ill, but they do very well and if they're aggressively treated with immunotherapy. And those are the patients who show up in your clinic a year later and are doing very well or often back at work. So these are patients that are worth identifying. Now I want to take a step back and talk about seizures as a whole in autoimmune encephalitis. So you may have noticed in the earlier slide that seizures are commonly part of the diagnostic criteria for possible autoimmune encephalitis, as well as definite limbic encephalitis. They can be the core presenting feature as well, and at times can be there prior to the onset of other neurologic features that suggest a diagnosis of encephalitis. The prime example of that is facial brachial dystonic seizures, which other people have named tonic seizures, which are associated with antibodies to LGI1. These seizures are pathognomonic for this autoimmune condition, and patients will experience, as you can see here on the left-hand side, very brief contractions of the face, oftentimes with the ipsilateral face or proximal leg contractions. And these contractions can alternate sides, often happen many, many times an hour. And while the initial description stated that the EEG is normal with these seizures, later publications identified that most of these patients with the more severe spasms, with the more severe seizures, will have a preceding diffuse electrodecrement, which is why some groups have advocated that these be called tonic seizures. And the important thing with this syndrome, although it's rare, is that many of these patients don't have a limbic encephalitis syndrome when they first develop the facial brachial dystonic seizures. They may have isolated seizures, and this is really a window of opportunity to identify an underlying autoimmune diagnosis, treat the patients early, and have them do better in the long run if you identify them and treat them early. The flip side to the question of seizures in the context of autoimmunity is patients who have chronic epilepsy and may not have had an encephalitis. So there's a population of patients who may have a chronic epilepsy and don't have clinically an autoimmune encephalitis syndrome. So we're talking here about patients who are walking, talking, and showing up to our clinics with recurrent seizures. And really, and when you're thinking about those patients who aren't actively encephalitic, who don't have encephalopathy, psychiatric disturbance, other neurologic features like movement disorders, and so on, those patients can either come in two categories. So the first category may be that many years ago, they had a clear clinical diagnosis of encephalitis. They recovered, they left the hospital, but they never stopped having seizures. So the epilepsy is now the primary neurologic issue that they are dealing with. And on the right-hand side is a figure from a paper written by an epileptologist in Spain who collected information about patients who had undergone epilepsy surgery, so who had chronic treatment-resistant epilepsy, but had been found to have neural autoantibodies. And those ranged from LGI1 to GAT65, MA2. And those were patients who had had antibodies identified. They had ongoing seizures for years, ended up having epilepsy surgery. And you can see here an example of a patient who has MA2 antibodies. You can see right amygdalar flare hyperintensity that extends posteriorly into the hippocampus. This is an ectal SPECT injection where you can see hyperperfusion of the right mesotemporal region. This patient underwent a temporal lobectomy. And then you can see on histopathology here that this patient has lymphocytic infiltrates. Even though it's been many, many years since the encephalitis, and even though clinically they don't look like they have encephalitis anymore, all that they have is epilepsy. And this is a group of patients that can be hard to treat because it can be hard to know when the patient stops having an autoimmune problem and when the problem becomes structural. So when this becomes sort of a burned out encephalitis in which there's no longer an active neuroinflammatory process. And we really don't have great biomarkers to make that distinction from an operational perspective. The second category is patients who never had a clear encephalitis in the first place. So they're showing up in your clinic. You asked them many, many years ago, were you ever hospitalized when the seizures first started, et cetera, and none of this ever happened. But when you do a workup, you end up finding that they have a high titer GAT65 antibody, for example. And when I'm thinking or when I'm talking about these two sorts of patients, the slide with the patient with facial brachial dystonic seizures and then the slide with the patient who undergoes a temporal lobectomy who has MA2 antibodies but has had epilepsy for years and years, I'm really referring to different entities. And this was something that the LAE Autoimmunity Task Force really wanted to focus on in terms of making recommendations. So they're conceptually very different entities. The first one, the patient with the facial brachial dystonic seizures, LGI1 antibodies, has essentially acute symptomatic seizures in the same sense that a patient who has an acute traumatic brain injury and is having focal motor seizures, for example, while they're in the ICU, has acute symptomatic seizures. So it's an expression, it's a symptom of a disease, and if you treat the underlying disease, then the symptom gets better. Whereas with the second category, so the patient who ends up having their temporal lobe resected many, many years after they had encephalitis, or the patient with high titer GAT65 antibodies who never even had a clear syndrome of autoimmune encephalitis, those patients really have epilepsy in the true sense of the word. So if we go back to what the definition of epilepsy is an enduring predisposition to generate epileptic seizures. So it's a chronic condition with recurrent unprovoked seizures. And those are two very different entities. So let me go into a little bit more detail. So when you're talking about acute symptomatic seizures secondary to an autoimmune encephalitis, this can happen from various types of antibodies, both antibodies against surface antigens like an MDA, LGI1, Caspr2, you can see the list here, and intracellular antigens like onconeural, GAT65 antibodies. When you're talking about autoimmune-associated epilepsy, so the chronic patients, really those tend to be either patients who had an autoimmune encephalitis, may have had acute symptomatic seizures with it, but continued to seize afterwards. And we'll talk about how these patients behave and what the determinants of post-encephalitic epilepsy are. And if you're dealing with a patient who never had a clear syndrome of encephalitis, those are typically patients with antibodies against intracellular antigens like onconeural antibodies like anti-HU, anti-MA2, or GAD65. And I'm not going to go into Rasmussen's here because that's a whole separate talk. And those are very different diseases in terms of their pathophysiology. And the former in acute symptomatic seizures, the antibodies themselves can lead to seizures, and that's been shown in experimental models. If you sprinkle patient's antibody on a rodent slice, or if you inject it intraventricularly, you can reduce the seizure threshold and you can cause seizures. So these antibodies directly cause seizures. Whereas in the second category, in autoimmune-associated epilepsy, it's a lot more complicated. And they sort of alluded to the fact that it's not purely autoimmune. So many of these patients have hippocampal sclerosis, they may have gliosis, so they have structural pathology that in and of itself could lead to recurrent seizures. Many also probably have ongoing brain inflammation that's primarily T-cell mediated. And we're not very good at distinguishing how much of each factor is playing a role, how much a patient has a structural versus an autoimmune problem. And this is why we came up with the term autoimmune associated epilepsy, not just the term autoimmune epilepsy, which has been in the literature a lot before, because it's really not just a pure autoimmune epilepsy in these patients. Many of them don't have an active autoimmune problem anymore, and treating them aggressively with immunotherapy may not help them. And that brings me to the next topic of therapy. So in the setting of autoimmune encephalitis and acute symptomatic seizures, immunotherapy is really the mainstay of treatment. So these patients often respond to immunotherapy and their seizures tend to not respond to anti-seizure medications. Whereas when you're thinking about autoimmune-associated epilepsy, really nothing really works very well, whether it's anti-seizure medications, epilepsy surgery, and unfortunately immunotherapy as well. Whether that's a function of us not using the right immunotherapy or whether many of these patients are not truly autoimmune, that remains to be seen. And lastly, the outcome is very different. So we'll talk a little bit about the seizure outcomes of autoimmune encephalitis in a minute, but many of these patients do well, whereas with autoimmune-associated epilepsy, many of them have refractory seizures and enduring cognitive issues. And so why bother distinguishing between these two entities? Is this just an intellectual exercise? Well, I don't think so. I think that we can all agree as epileptologists that having a diagnosis of epilepsy means something. You know, these patients need to take chronic anti-seizure medications. There's a lot of social implications with having a chronic neurologic diagnosis. There's social stigma that comes with it, driving restrictions. I don't think we should take lightly labeling someone as having an autoimmune epilepsy when really they just had acute symptomatic seizures. So that's number one. And number two is that they're just different diseases. And so it has important clinical and scientific implications. And we really shouldn't be lumping together conditions that are very different biologically speaking and clinically behave very differently. So now thinking about what determines the outcome of autoimmune encephalitis if we're specifically thinking about seizures and the epilepsy side of things. So this was one study done by a group in Germany that looked at the long-term follow-up of patients with an antibody-mediated encephalitis. And here you can see Kaplan-Meier survival curves where each tick here on the x-axis is 1 year. So they looked at very long-term outcomes. And here the green curve indicates how many patients stopped having seizures. And the red curve indicates how many patients, when the patient had their last seizure ever. So some patients first stopped having seizures and had a recurrence, then had a last final seizure freedom period. And the blue line is how many patients were able to stop anti-seizure medications. And so basically what you'll see here is that in patients who have antibodies to cell surface, so for example, LGI1, Caspr2, and MDA, the majority stop having seizures. Okay, so you can see that there's really only about 20% that are still having seizures after a few years. And about a third of them were able to get off anti-seizure medications. Whereas if you look on the right-hand side, patients who had intracellular antibodies, so GAT65 and THU, never stop seizing and never get off anti-seizure medications. So that's number one. The type of antibody target really drives as a primary driver of autoimmune encephalitis outcomes. But it's not so simple. And in fact, if you dig into the literature, there's been very wide variability in the reports of persistent seizures. So, in one Dutch cohort from Martin Tittelayer's group, 1% of patients with either LGI1 and MDA or GABA B encephalitis were reported to then develop chronic epilepsy. It's extremely low. And another group, Chinese cohort, about a third had ongoing seizures, so huge variability. If you look at specific types of encephalitides, there's still variability. So in LGI1, one Chinese cohort then reported that no patients had ongoing seizures, and then the Mayo cohort showed that at 2 years, 1/5 of patients continued to have seizures. And I have to say that that reflects my experience more. I used to feel really badly for my patients, that I was not doing something right with them. You know, all this literature was saying that none of them still have epilepsy at the long-term follow-up. And I do have patients who continue to have seizures. And I thought, well, maybe I'm not treating them right. And really the latest evidence does show that a proportion of these patients will continue to seize if you follow them for long enough. On the other hand, the literature is pretty uniform that patients with an MDA generally stop having seizures. And lastly, the literature with GABA B is not so bright. I mean, in one cohort, about half of them are continuing to have seizures. And in general, the prognosis with GABA B encephalitis is not as good. Many of these patients are paraneoplastic, have an underlying malignancy. So that may relate to some of the poor outcomes. And then if you look at all comers, so if you don't divide according to antibody, about a third of acute symptomatic seizures from encephalitis will end up transforming into epilepsy and show up in our clinics. And not all of those, third are attributable to an intercellular antibody. Some of these patients will be cell surface antibodies. So I think we need to be a little bit less uniformly optimistic when we counsel our patients with cell surface antibody encephalitis that they'll for sure be able to come off medications and not have epilepsy, because that's truly not the case. And the second thing is, when you're meeting a patient, it may not always be clear whether you're dealing with acute symptomatic seizures from an autoimmune encephalitis or an autoimmune-associated epilepsy. So I think those conceptual definitions are an important first step. I believe in it because I was part of the group that came up with it, but I recognize that it can be difficult to implement. And so I'll give you some examples. For example, I saw a patient recently who had been having seizures for about a year, but there were many aspects of her history that were consistent with an autoimmune cause of seizures, lots of cognitive issues, very frequent subclinical temporal lobe seizures on the EEG. Her PET scan showed hypermetabolism. She ended up having LGI1 encephalitis. It's been going on for a year. When I meet her, is she chronic at this point? Does that mean she has autoimmune-associated epilepsy because it's been going on for 1 year? Or is this still acute symptomatic seizures? Because of a case like this, we decided to advise against having a strict timeline, to use a line in the sand that at 1 year you start having epilepsy, but before 1 year it's still acute symptomatic seizures. We didn't feel was fair to the process that these patients often go through. Many of them have a delayed diagnosis and may come to someone who realizes that they have an autoimmune problem later. And therefore, we really can't use a strict timeline. And we said that if there is an evidence of an active autoimmune encephalitis on the basis of clinical and paraclinical data, then you're dealing with acute symptomatic seizures. And conversely, some patients never have a clear autoimmune encephalitis in the first place, like patients with high titer GAT65, temporal lobe epilepsy. And so in these patients, it can be hard to make the distinction. And the last thing I'll say is that patients who did have a clear autoimmune encephalitis, sometimes even many, many years after the initial illness, can have evidence of neuroinflammation on histopathology, for example. And does this mean that they still have an active encephalitis? Does this mean that there's an active autoimmune process, but they have an autoimmune-associated epilepsy? What does that mean practically in terms of how we should be treating these patients, whether immunotherapies should still be the core treatment approach? We really don't have the answers to that. And so really, essentially, I think there's still a need in the field for an operational definition of acute symptomatic seizures versus autoimmune-associated epilepsy to really guide clinicians on what to do, guide clinicians on whether you're okay to withdraw anti-seizure medications or whether you should escalate immunotherapy. And I will argue that the main diagnostic challenge that we're now faced with is autoimmune-associated epilepsies. I think that we generally as neurologists now are good at recognizing the NMDA receptor encephalitis patient that I presented earlier. You know, most neurologists would meet this patient and send a panel right away and not wait for the panel to treat the patient. The issue is the patients who are walking around, walking, talking, showing up in an epilepsy clinic who don't have the typical encephalitic features, but may have an neural autoantibody. We did a systematic review of studies that looked at epilepsy populations and systematically investigated these patients to look at how many of them carried a neural autoantibody. And the conclusion was that there was a very wide variability in terms of the reported range of antibody positivity frequency amongst these populations. But really, if you look at the most rigorous studies, the studies that explicitly excluded patients that had a clear autoimmune encephalitis like an MDA, and studies that had rigorous antibody ascertainment, the answer is probably about 5% of focal epilepsy of unknown cause has an underlying antineural antibody. And so I just want to talk to you about a case that really exemplifies the problem that we're often faced with as epileptologists. So this is a woman who was presented at an epilepsy surgical conference at my institution. She's 43. She has no epilepsy risk factors. She's had drug-resistant focal epilepsy for 8 years, so since age 35. She has focal aware seizures with auditory hallucinations, which may or may not evolve to receptive aphasia, and at times these evolve to bilateral tonic-clonic seizures. She has a non-lesional MRI, bilateral temporal hypometabolism, multiple seizures captured from independent left and right temporal regions, and neuropsych profile shows dominant rather than non-dominant temporal dysfunction. She's had postictal psychosis before, and she now has treated depression. Okay, so is this someone that if you saw in your clinic, you would think, well, I should do an autoimmune workup? And I suspect that not everybody in the audience would agree on the answer. Many of you would say, well, yes, I would actually, probably send a serum panel. Some people would probably say, well, this is pretty typical non-lesional epilepsy. No, I wouldn't. And so what data do we have to drive this decision that I just asked you to make? So we have clinical predictive tools that have been developed. The first one that probably many of you know is the Antibody Prevalence and Epilepsy Score, or APE score, that was developed by Div Dubé, originally in Texas, then validated in Mayo. And this is a score that uses various elements which are listed here, including new onset rapidly progressive mental status changes, new onset seizure activity, neuropsychiatric changes. I won't read through all of them because you can see them. And this one tested in a group of patients presenting with seizures or cognitive dysfunction suspected to have an autoimmune encephalitis. This performs well, both in terms of sensitivity and specificity. The one thing that you'll notice here is that many of these clinical features are features of encephalitis. They're not features that you would ever see in a patient that would show up in an epilepsy clinic, or most of them are not. And so the question is, well, how well does this perform in a clinical setting of a patient with a chronic epilepsy that you're wondering may have an autoimmune cause? And so more recent tools developed by other groups have tried to be relevant to the scenario in which we as epileptologists are often faced with. So a patient who does not clinically have an autoimmune encephalitis and is showing up to an outpatient epilepsy clinic setting, but has, focal epilepsy of unknown cause. And so the one tool that probably has been developed with the highest number of patients and most importantly validated in an independent cohort is the ACEs score tool. It stands for the Antibodies Contributing to Epilepsy and Seizures tool. And it was developed by the Dutch group, Martin Tilleier's group. And you can see the features here: cognitive symptoms, behavioral changes, dysautonomia, speech problems, a personal history of systemic autoimmune disease, and lastly, temporal MRI hyperintensities. This score was developed explicitly in a cohort that was excluded from having a clinical diagnosis of encephalitis, but what one can't help but notice is that these are still features of encephalitis. They're likely just a mild form of encephalitis. So there's still general neurologic features of encephalitis, and there's very little in there that relates to epilepsy characteristics, like what types of seizures, what the EEG may show. The other tool that was developed was the following from the Oxford group by Sarah Shamrani's group, in which older age, piloerection semiology, mood changes, limbic changes on MRI were predictive of an antineuronal antibody, while epilepsy risk factors or absence of epilepsy risk factors and normal attention scores were not predictive. And this tool was not validated in an independent cohort, and they found that a score of 1 or above was predictive of antineuronal antibody positivity. And lastly, a group in Stanford took the APE score, added some elements to it, which are bolded here, which I won't go into detail because I want to have some time for questions, and then validated that or applied that in a group of patients who were going to undergo surgery, so being considered for epilepsy surgery in order to determine whether we should stop and perhaps, do a trial of immunotherapy if they had an antineuronal antibody. So all of these scoring tools play a very different role depending on the situation that you're in. So the APE score, which has been revised to the APE2 score, probably makes the most sense if you're dealing with a patient who clinically looks like they may have an autoimmune encephalitis. So they're, encephalopathic, sick enough that they're, maybe hospitalized. And in that setting, using the APE2 score makes sense. You test autoantibodies in serum and CSF. You consider a malignancy workup. In patients who don't have a clear encephalitis, but in whom you're suspicious that there might be an autoimmune process going on causing the recurrent seizures, then the ACEs score is probably the best tool there is right now because of the fact that it's been validated in independent cohorts. And in that setting, if the ACEs score is 2 or more, in a recent publication, we recommended testing autoantibodies in serum and consider CSF. In the epilepsy setting, so in autoimmune-associated epilepsy, because you're likely going to deal with antibodies that tend to be just as sensitive, if not more sensitive in serum, like LGA1, GAD65, Casper2, then testing CSF may not always be necessary, although we don't truly know the answer to that question. But because of that, we didn't recommend doing CSF in everybody with a suspected autoimmune-associated epilepsy. And lastly, considering a malignancy workup depending on the situation. But I just want to pause and say that, the premise behind all of these prior studies that have developed these scoring tools is that positive antibody means autoimmune-associated epilepsy. Negative antibody means no autoimmune epilepsy. There's a problem with that premise. So there's 2 sides to this problem. What if you're dealing with a false positive? So the devil is in the details with a lot of these studies in different groups, different reputable groups with lots of experience doing neuroimmunology actually define what a positive is differently. And there are, different types of antibodies that may have, risk of false positivity, like glycine receptor, for example. MA2 can be a difficult assay from what I hear from my neuroimmunologist colleagues. How neuropil antibodies without a characterized target is defined, it also varies according to the study. So it's not so cut and dry what a positive antibody is and what it means. The other side to this is there are patients who have a clear autoimmune encephalitis clinically. They have bilateral mesial temporal flare changes on MRI. They have an active CSF, but they don't have an antibody. Does that mean that they don't have an autoimmune process? Probably not. There is an entity of antibody negative autoimmune encephalitis. So is it possible that there are patients out there that have antibody negative autoimmune associated epilepsy? Maybe. And really, we don't know enough to define that entity yet. And that's kind of a slippery slope right now to go down on because you don't want to be over-treating patients who may have, a non-autoimmune chronic epilepsy, but the question is out there as to whether that's an entity. I'm going to skip this slide and talk briefly about what we know that could help us create better scoring tools that would be applicable to the epilepsy clinic. So we know in the context of autoimmune encephalitis that patients tend to have high seizure frequency, short seizure duration. Their seizures tend to change over time, so they have a dynamic epilepsy, and they're typically intractable to a high number of anti-seizure medications early in their disease. And then there's specific antibody associations, like I've talked about already, like LGI1 and facial brachial dystonic seizures, as well as the syndrome of musicogenic epilepsy and GAT65 antibodies. So perhaps some of these features may be helpful in the future to improve on some of those scoring tools that we have. We know from prior studies that the semiology can be informative. So patients with autoimmune encephalitis often have auras or focal aware seizures that involve multiple sensory modalities like auditory, somatosensory, gustatory. And they may also have motor seizures like epilepsy partialis continua. And their EEG tends to not be pure temporal. As you can see here in this patient with LGI1, they tend to be more centrotemporal, which implies that the epilepsy in these patients or the seizures are not purely limbic. They tend to be temporal plus. And so I'll just end with the basic approach that I usually talk to our residents here about. Once you have decided based on the data that you have that the patient is reaching your phenotypic threshold, where they choose to use the scoring tools that I've talked about, whether it's some of the electroclinical features that I just mentioned. Obviously, autoantibody testing is important. So at NYU, we have created a panel in which we have decided that in the US, the Mayo panel is the most complete and the most reliable, but on depending on which country that you practice in, you would have to decide if you have access to antibody testing where the panel would be the most reliable. I typically tell our residents to avoid panels that are labeled as paraneoplastic because many of them here in the US don't include cell surface antibodies that are really relevant to autoimmune encephalitis. Like I've said, I generally always tap patients when they're acutely ill, when they clearly have an autoimmune encephalitis. But if you have a medium or low pretest suspicion, I don't always tap patients when I'm not very convinced in the first place that I may be dealing with an autoimmune process. And I'm going to end with a case of a 72-year-old woman who was previously high functioning. She presented with new onset memory disturbance for 2 weeks. She had severe episodic memory impairment on testing and was found to have frequent focal impaired aware seizures with right temporal EEG onset. Her MRI showed bitemporal flare hyperintensities, and she had a very mild lymphocytic pleocytosis. The point here is that this patient did not have any antibodies, but she still had acute symptomatic seizures from an autoimmune encephalitis. And so these are the diagnostic criteria for definite autoimmune limbic encephalitis. There's no antibodies in there. In fact, if you didn't have access to antibody testing, you could still make a diagnosis and you could still treat this patient. So that's an important thing to note, is that antibody testing is really not the end-all and be-all of the diagnostic process, and it matters much more to have good clinical acumen and make an interpretation of the clinical and paraclinical tests that you have available to you to determine what's your pretest probability that a patient's an autoimmune process. Other important aspects of the diagnostic workup are a malignancy screen. I definitely do that if patients are antibody positive in terms of, antibodies that have a risk of an underlying malignancy. And if they're antibody negative, I only do it if a patient has a paraneoplastic syndrome, for example, outside of the world of epilepsy. If someone has a cerebellar degeneration or subclonus myoclonus, then I usually do a screen. And then finally, ancillary testing is often helpful in the context of following patients after treatment. So many patients with autoimmune-associated epilepsy or autoimmune encephalitis can have frequent seizures, and that can be a good objective marker of disease. So for example, I often serially get EEGs in patients with GAT65 or LGI1 who have frequent subclinical seizures to help me get a sense of whether their seizures are as well controlled as they think. The MRI, I often get as follow-up to see if there's any evidence of hippocampal sclerosis and to see if there's any evidence of a structural cause of epilepsy. And lastly, I often get PET MRIs in patients who are entering the chronic phase. I've been treating them for over 6 months. They're still having severe seizures, and I want to know how hard to push for aggressive immunotherapy, because when I see hypermetabolism, that can sort of support that route. And that's, I lied, I had one last case. So this is Another question that often comes up is whether you need to biopsy a patient to know whether they have an autoimmune problem. I think it's really very rarely necessary. And the main goal of a biopsy is to exclude another non-autoimmune process. So this is a patient who was hospitalized, and the team called me saying, we have a patient with encephalitis, I want you to see them. And I went to see her, I looked at the MRI, and I was a little bit concerned that this was not autoimmune. So I really recommended that this patient should have a biopsy, and in fact, she had gliomatosis cerebri. So most of the time, you don't need histopathology to establish an autoimmune diagnosis, but you should get histopathology to rule out alternative diagnoses if the clinical picture or the imaging suggests that's what you're dealing with. So today I've talked to you about how acute symptomatic seizures secondary to autoimmune encephalitis are very different entities than autoimmune-associated epilepsy, and I've highlighted some of the diagnostic tools that you have that can help you screen patients with seizures and epilepsy and identify potentially autoimmune patients. And so we have a couple of minutes for questions.
Thank you. That was a very, very interesting discussion. So we have some questions. The first one will be, for how long can you suspect a patient can be, can have the cause of his or her epilepsy as autoimmune? If, for example, you have a patient that has been with epilepsy for 10 years, and his or her epilepsy is already under control, it hasn't been like very, very active, but from one moment to the other, that epilepsy starts like being very, very active with a lot of seizures, daily seizures, and with no other components, only that. Can you still kind of suspect that could be autoimmune?
Yeah. So I think there's two questions here, is what's the likelihood that something is autoimmune? And more importantly, what's the likelihood that if it is autoimmune, it'll respond to therapy? So it's, in terms of the patients who have a chronic epilepsy and turn out to be autoimmune, some of them can have a fluctuating course. Like I've certainly seen patients with GAT65, for example, go through periods where their seizures are improved, typically not for years, but sometimes for months at a time. And then the seizures recur and become more frequent. So I think having relapses or fluctuations in seizures can definitely happen in patients with an autoimmune cause of seizures. Unfortunately, and so I do think that whenever a patient who may have been doing well before becomes all of a sudden very refractory and there's no other clear cause for their seizures. So obviously, you know, you're not going to do an autoimmune workup if your MRI shows a focal cortical dysplasia. Some other causes of seizures can sometimes have fluctuations, but if there's really no clear cause and you're dealing with a phenotype that goes along what I discussed, I think it's fair to do a workup. Most patients who have a chronic course don't respond very well to immunotherapy. I tend to try immunotherapy anyway, because even if they don't become seizure-free, many of them can have a seizure reduction, and those tend to be sick patients, and having seizure reduction is worthwhile for them. But it really depends on the individual situation.
Okay, so another question regarding treatment. So what would be the ideal steps that you should take to start treatment with this kind of autoimmune epilepsies? Is it better to start with the steroids and afterwards to start with plasmapheresis, or to do the other way around, or to start several treatments at the same time?
I think it really depends on the clinical situation. So when you're dealing with an acutely sick patient with an autoimmune encephalitis who's hospitalized, you know, a patient with an MDA receptor encephalitis, I usually don't try first-line therapies in sequence. I try them all at once. So I'll give them steroids, IVIG at the same time. And if they fail that within a week or two, if they're sick, they're in the ICU, then you escalate to second-line therapies like rituximab. On the outpatient basis, so in a patient with an autoimmune-associated epilepsy, I tend to do things in a more staged manner because you do have a little bit more time. And I tend to do more prolonged treatment trials. So in patients who are chronic, I tend to do, a 2 to 3 month trial of generally steroids. Honestly, from a practical perspective, in the US, it's easier to get steroids approved by insurance than IVIG, which is like a primary reason that we do that first when you're trying first-line therapies. So I'll do like a 2 to 3 month trial and follow their seizure diaries. I often follow EEGs if they've been shown to have subclinical seizures before, to see whether this is immunotherapy responsive or not, and to decide whether, if there's immunotherapy response, I'll start a steroid-sparing agent, which, you know, can be eventually IVIG or some oral steroid-sparing agents like mycophenolate or azathioprine. So the approach in terms of how aggressive you are about using various agents in sequence or at the same time, and over how long you assess treatment response, really depends on the acuity of the illness and whether you're dealing with an acute autoimmune encephalitis or a chronic autoimmune-associated epilepsy. And the other thing that I'll say is that I've recently started using more biologics in patients with actually both autoimmune encephalitis that's very refractory, but also autoimmune-associated epilepsies. Like I've had some GET65 patients respond well to tocilizumab, for example. So I have been trying to use that in refractory patients, and I always tell them, like, we have no evidence for using this. This is completely, you know, experimental to a degree. You know, there's no randomized controlled trials of these agents, but those are sick patients who have very bad seizures, high morbidity, and they're often willing to try it. And I've had more patients who haven't responded than patients who have, but because we have such limited options in these patients, I think it's worth trying.
And of course, those particular patients are going to be more refractory to everything. So anything that you can do to improve their life, it's going to be so much better.
Yeah, and you know, recently I actually did a debate with Div Dubé at a conference where we had to debate. So I was the pro non-immunotherapy approach. He was the pro immunotherapy approach, because obviously he's the immunologist and I'm the epileptologist. So we talked about patients who are refractory to first-line immunotherapy. So patients with GET65, for example, in whom you do a steroid trial. And the question was, well, when a patient doesn't respond to first line, do you go to second line or do you try other epilepsy approaches? And so I don't think it's one or the other. You don't have to pick. But my talk was about how we have effective epilepsy treatments. Like, for example, there's some data on responsive neurostimulation in autoimmune-associated epilepsies. There's some data on vagus nerve stimulation and so on. So I don't just focus on the immunotherapy approach. And honestly, it often isn't completely effective in isolation.
So this takes us to another question. So regarding surgery, epilepsy surgery, how good is the outcome in this particular population with autoimmune encephalitis and autoimmune epilepsy?
So not great. I generally am a bit uncomfortable with resection in these patients, especially if it's still early after when they had encephalitis, because the concern is that their epilepsy may be dynamic. They may be in one temporal lobe right now, and in a couple of months, it may be in the other temporal lobe. And if you look at the publication that I showed earlier from Mark Carreño, who looked at epilepsy surgery in patients with antibodies, the majority of them were angle 3 or more. Some of them had some improvement, but I worry a little bit about doing epilepsy surgery in these patients, unless they're like very, very chronic. You know, it's been 10, 15 years and they have very concordant data pointing to, you know, one, like the unilateral temporal lobe, which is really not what we see. You know, most of these patients who had encephalitis, when you do an epilepsy surgery workup, they have bilateral independent epilepsy, and it's not pure temporal. It tends to be temporal perisylvian. So those are patients that generally do not do well with resection. Is there a role for palliative resection in some selected patients who have very, very bad seizures? Maybe. There's a growing literature, a small but growing literature on neurostimulation in these patients, because most of them are really not great surgical, like resective candidates.
And from that point of view, from the neurostimulation therapies, which one has been like the most successful one with these patients?
Well, here in the US, we would do responsive neurostimulation if they have only two foci. There's a report of deep brain stimulation in Australia from Lisa Gillander's group with the anterior nucleus of the thalamus. And vagus nerve stimulation has been reported to be helpful in some patients with post-encephalitic epilepsy.
Okay, so one final question. How much time do you have to wait for maintaining steroids without response? And if you kind of titrate the steroids before changing to another therapy, or do you just add on, or what are your recommendations regarding this?
So I think it really depends on how confident you are that you're dealing with an autoimmune process in the first place. I mean, there are steroid refractory autoimmune cases. So that's number one question you have to ask yourself before you make a decision, is how convinced you are that you're really dealing with an autoimmune problem, because you don't want to go down the rabbit hole of trying immunotherapy after immunotherapy in a patient who actually turns out that, they just had a low titer GAT65 that had nothing to do with their epilepsy. Okay, so that's number one. Number two is, did they have some response to steroids? So, response is not an all or none thing. There are some patients that will become seizure-free with steroids. Those are usually autoimmune encephalitis, LGI1 antibodies. But many patients, for example, with GAT65 will have some seizure reduction, but, not seizure freedom. And in that case, I tend to keep some steroids on and I slowly taper them while I add something else on to augment it. And I don't like, chronic long-term steroids. If there's some response to steroids, then I try to initiate some steroid-sparing therapy, whether that's IVIG or oral steroid-sparing agents, or in, patients who need second-line rituximab.
Thank you. So there is a last question. So are you aware of any intracranial EEG implantations inadvertently carried out in a patient with LGI1 associated with dystonic seizures, this focal brachial dystonic seizures?
I'm not. Is the person asking the question aware of it? Because I would love to know where it comes from, but I would not dare to put a electrode in that brain. I think or if I did, I wouldn't publish it afterwards.
Yeah, that would be very difficult.
It would be a bit embarrassing.
Yeah, definitely. So apparently this is it. So thank you very much. This was a very interesting subject, a very interesting discussion. It was a pleasure to have you with us.
Thank you for having me.
Thank you. So we won't have a webinar on May because we will be at the North American Epilepsy Congress. That is going to be next month. And our next webinar will be launched in June. Thank you very much. Have a nice evening.